Good morning. This is Nick Weislogel with the Health Policy Institute of Ohio. Thanks for joining us for HPIO's webinar on the 2019 Health Value Dashboard. Please note that to reduce any background noise, your audio has been muted. Slides from today's webinar will be posted on HPIO's website later this afternoon. We're also recording the webinar today and we'll be posting that video on our website as well. All materials related to the 2019 Health Value Dashboard, including an 8-page executive summary, Excel data appendix, and equity profiles are available at www.hpio.net. We're going to start today's webinar with an overview from HPIO Vice Presidents Reem Alley and Amy Bush-Stevens on the findings of the dashboard and how Ohio can improve our state's health value. If you have any questions at any time throughout the webinar, please feel free to type them in the question box and we'll answer them as soon as we can. And now here's Reem.
Good morning. Thank you for joining us to learn more about the 2019 Health Value Dashboard. You can see pictures of myself and Amy Bush-Stevens. Will be discussing with you the findings from the dashboard, and then we'll be joined by a panel later on this morning. As Nick mentioned, if you have any questions, please feel free to type those questions into the question box, and we will respond to them both throughout the presentation and at the end of each of the presentations. Please join us on Twitter. If you tweet, you will see our handles are listed here, and we really hope that you are engaged throughout the conversation. This is, as I mentioned, the third edition of the Health Value Dashboard. The first edition of the dashboard was released in 2014, the second in 2017, and we are committed to updating the dashboard every 2 years. We'd like to get a sense of how many of you have used the dashboard in your work, either the current 2019 dashboard or previous versions. So we're going to throw up a quick poll question for all of you to get a sense of whether or not you have used the dashboard 2014, 2017, or 2019 edition in your work. We'd love for you to select all that apply. So if you have been a consistent user of the dashboards over these past 5 years, we'd love to see that reflected in the poll results. If you're new to the dashboard, let us know. We want to make sure that we get good participation from everyone. So if everybody could make sure that they answer the poll question, that would be great. All right, now we're going to go ahead and share those results. All right, so about 1/5 of you have used the 2014 dashboard. So you guys are old timers. You are very familiar with this work. And then we have about 40% 2017, 30% for 2019, and about half of you have never used the dashboard in your work. We hope to change that with this webinar, and Amy will share some ways that you can use the dashboard in work that you do. The dashboard compiles publicly available data in one place on health spending and the drivers of health, and examines Ohio's rank and trend performance relative to other states. It is an important starting place to assess where we are and how we can improve to get to the finish line, an Ohio that is healthy and where healthcare spending is sustainable. The dashboard was developed with a policymaker audience in mind and is constructed to be concise, at a glance, and tell a story about Ohio's performance. We worked with a multi-sector advisory group, including all the sectors that you see here, to develop the dashboard. And I know that many of our health measurement advisory group members who helped us in developing the dashboard are listening to the webinar today, and we really thank you for your contributions to this work. And we contracted with researchers at the Ohio University Voinovich School of Leadership and Public Affairs for data compilation and analysis. Now, for what you're really here for, let me share with you where we rank in Ohio. We are 43rd on population health and 28th on healthcare spending out of 50 states and the District of Columbia. Our health value rank is a composite measure of our population health and healthcare spending metrics, equally weighted. Like the last edition of the dashboard, we rank 46th on health value, putting us right in the bottom quartile of states and DC. Ohioans continue to have poorer health and spend more on healthcare than people in most other states. Looking at the distribution of ranked metrics, Ohio is in the bottom quartile of states in DC on nearly 30% of metrics. And we are in the top quartile on only 5%. There is clear room for improvement. When we look at how other states rank, we see some interesting regional patterns. Here is state ranking on the population health domain. States in the green have the best population health outcomes, and states in the red have the worst health outcomes. States in the bottom quartile for population health are clustered toward the center of the country, from Michigan to Louisiana, encompassing portions of the Midwest, Appalachia, and the South. The map here shows healthcare spending rank. Green indicates lowest healthcare spending, and red indicates the highest healthcare spending. On spending, there continues to be a demarcation between states in the South, which tend to have lower healthcare spending, and states in the North with higher healthcare spending, with some exceptions towards the Northwest coast. And this is consistent with what we saw in the last edition of the dashboard. And now here you see a map of where states rank on health value. Here, states that are green have the best health value rank, and red have the worst health value rank. Again, you'll note that there is a clustering of states that are in the bottom half of health value. Ohio, joined by neighboring states, again through the Midwest towards the South. And then a clustering of states on the east and west coasts that are in the top half of states on health value. There is a great deal of diversity in the top quartile states on health value. There are states with poorer and older populations than Ohio, such as Arizona and Oregon, larger or more diverse populations, such as California, or smaller populations like Hawaii. We did a correlation analysis to assess the impact of age, looking at percent of the population over age 65, and poverty, looking at both adult and child poverty, with health value rank. And what we found was that there was a relatively weak correlation, which confirms that age and poverty are not driving the bus on health value. We found that of the domains in the dashboard, the public health and prevention, social and economic environment, and physical environment domains were most strongly correlated with our population health rank. As you can see, we are in the bottom half of states on all three of these domains. Based on this and a review of the dashboard data, we were able to point to three primary factors driving Ohio's poor health value rank: large disparities, resources tipped in favor of treatment instead of prevention, and the addiction crisis are driving Ohio's poor performance on health value. We are leaving far too many Ohioans behind. Data from the dashboard equity profiles demonstrate that communities of color, Ohioans with disabilities, with lower income or educational attainment, or who are sexual or gender minorities, experience the poorest health outcomes and face multiple barriers to health. Barriers faced by these populations include unequal access to post-secondary education or a job that pays a self-sufficient income, the ability to buy healthy food, and increased exposure to adverse childhood experiences, violence, racism, and discrimination. Ohio performs poorly on many of these critical measures that support and impact health throughout life. There are also large gaps in outcomes across these measures, and hundreds of thousands of Ohioans would be impacted if these gaps in outcomes were eliminated. Some of the largest gaps in outcomes we noted in the equity profiles were around housing quality. Having a place to live is a basic need that is fundamental to our health, and affordable quality housing is critical. Poorly maintained or older homes pose increased risk of exposure to pests, allergens, lead, and other toxins that can be incredibly harmful to our health. You'll see from the map here that lead exposure and contamination is a serious issue for children in Ohio. Even low levels of lead exposure can have harmful effects on children's health and behavior, including developmental delays, learning disabilities, and damage to the brain and nervous system. Another factor driving our poor health value rank is that our spending and resources are out of balance, tipped in favor of downstream treatment instead of upstream prevention. Ohio performs poorly on many of the factors that influence our overall health, although we do perform relatively well on access to care. Researchers estimate that only 20% of the modifiable factors that influence health are attributed to clinical care. 80% of overall health is shaped by non-clinical factors within our social, economic, and physical environments, such as access to quality education and housing, as well as our health behaviors. This indicates that access to quality healthcare is necessary, but addressing access to care alone is not sufficient for getting to good health outcomes. Ohio is in the bottom quartile on measures related to nursing home care spending, hospital spending, and Medicare beneficiary spending, particularly for those with complex health issues. Ohio's per-person spending for older Medicaid enrollees, the aged eligibility category, is 1.4 times more than the U.S. rate. Ohio's healthcare spending is focused on costly downstream care to treat health problems, largely due to many missed opportunities to prevent or better manage injury, illness, and disability for thousands of Ohioans. State and local public health funding provide critical resources for prevention services, including tobacco prevention and cessation and senior falls prevention. However, as you can see, fewer state dollars are allocated to prevention and public health. In addition, state funding for prevention and other health-related agencies is relatively small. The third factor we identified contributing to Ohio's poor health value rank is addiction, a complex problem at the root of many of Ohio's greatest health value challenges. Ohio is solidly in the bottom quartile on several addiction-related metrics and performs poorly on both tobacco use and secondhand smoke exposure. The map that you see here shows a group of 13 states stretching from the upper Midwest to the South, dubbed as the Tobacco Nation by the Truth Initiative, which was established as part of the 1998 Master Settlement Agreement between major U.S. tobacco companies and states. Tobacco Nation states have the highest rates of adult smoking in the U.S. and higher smoking rates than many of the most tobacco-dependent countries in the world. Here are states in the bottom quartile on population health in the dashboard. When you look at these side-by-side maps, it's pretty shocking. We found a very strong correlation, about 0.94 for adult smoking and population health rank, which makes it clear. Tobacco use in our state drives poor health and poor health value. In fact, all states in the top quartile for health value have lower rates of adult smoking than Ohio. To recap, we are leaving far too many Ohioans behind, and not all Ohioans have the same opportunity to be healthy. Our resources are tipped in favor of costly downstream care instead of prevention and healthy aging, and addiction, especially tobacco use, is driving our poor health. Now, I know I've shared quite sobering news, but the good news is that there are many evidence-informed opportunities we can pursue, both through policy change and public-private sector collaboration to improve. And my colleague, Amy Bush-Stevens, is going to talk a little bit more about what those strategies look like.
Good morning, everyone. This is Amy Bush-Stevens at HPIO, and I'm going to advance to the next slide here. There we go. Reem has just painted a clear picture of the many problems facing our state, which can seem somewhat overwhelming. But the good news is that there are evidence-informed strategies that can improve outcomes, control healthcare spending, and reduce disparities. Improvement is definitely possible. In the dashboard, we see that other states have shown that better outcomes can be achieved, and we highlight evidence-based strategies that can be better deployed in Ohio to improve health value. We identify 3 policy goals in the dashboard. These goals come from the 3 reasons why Ohio performs poorly on health value that Reem just talked about. And then we get even more specific in the dashboard and narrow down to these 9 specific strategies. And now I'm going to dig into why these strategies are so important. And later in the webinar, Bree and Kellen and Alicia will be talking about relevant changes in the state budget and other state policy issues that are relevant to these strategies. We'll start with creating opportunities for all Ohio children to thrive. These 3 strategies here have been getting a lot of attention lately. They have a lot of momentum around the state, including leadership from the governor, and Bree will be saying more about that in a minute. And I want to say a little bit more about number 3, lead screening and abatement or mitigation. At the local level, parents and other stakeholders have formed groups to reduce lead poisoning around the state. This is one example. The Concerned Citizens Organized Against Lead in Cleveland, this is their Facebook page, and there are many other groups around the state that are working on this issue. At a state policy level, we can increase funding to the state's lead poisoning prevention fund so that more houses can receive mitigation services, and we can expand lead abatement workforce, the workers who are certified to safely remove lead paint or encapsulate lead paint around windows and doors. And the recently passed state budget did include $25 million for lead poisoning prevention strategies, including lead abatement and remediation assistance, a tax credit for abatement, and funding to increase the supply of lead hazard control workers. Historically, there's been a lot of resistance to doing lead abatement because it is expensive. But if you look at the whole picture, lead mitigation actually yields cost savings. These savings are the result of children being able to live to their full potential. Now let's take a look at the 3 strategies under the policy goal, invest upstream in employment, housing, and transportation. Later in the webinar, we're going to hear more about housing from Kellen, who's with the Ohio Housing Finance Agency. For transportation, number 6, we have recently seen an increase in state funding for public transit in Ohio, which historically has been quite low. I want to say a bit more about the Earned Income Tax Credit, or the EITC, which is an important tool for supporting low-income working families that could be strengthened in Ohio. Research shows that the EITC can lead to improvements in health, particularly for birth outcomes, which are certainly a big area of concern in Ohio. In addition to the federal EITC, Ohio has a state EITC. There were changes in the transportation budget that slightly strengthened Ohio's EITC. So removal of a cap and an increase in the rate from 10% to 30% of the federal credit. The next step for strengthening the EITC would be to make it refundable. Refundability would mean that the credit could help many more low-income families. As shown on this map, many other states already have refundable EITCs. The third policy goal is about addiction, including opiates, alcohol, cocaine, methamphetamine, tobacco, and other drugs. The opiate crisis and overdose deaths have gotten a lot of policy attention in Ohio over the past 5 years, as they certainly should, and much has been written about how to address this crisis, including the 2 HPIO publications here from our Addiction Evidence Project, and this report from Recovery Ohio, and Alicia Nelson from Recovery Ohio will be saying more about this later in the webinar. I'm going to use my remaining time today to focus on tobacco because it's an issue that tends to get less policy attention, and it clearly affects Ohio's health value rank in many ways. I'm going to encourage us to dream big here and have a vision. Imagine what it would look like if Ohio took tobacco reduction seriously. Here's what it would look like. All Ohioans who want to quit smoking would get the help they need, and the current generation of kids in elementary school today would never start using nicotine. Here are some components of what effective cessation policy would look like. Media campaigns like tips from former smokers. Imagine that those are everywhere, that cessation is prioritized in Medicaid managed care reprocurement, leading to more Medicaid enrollees getting cessation counseling and medication, and that cessation services are tailored to meet the needs of Ohioans living with toxic stress, mental illness, and disability. Media campaigns are extremely effective, particularly for motivating people to quit. The Tips from Former Smokers campaign drives calls to the quit line. Unfortunately, our quit line in Ohio is underutilized. In order to boost use of the quit line, we could invest more in media campaigns and raising awareness. And Medicaid could encourage increased use of the quit line, holding managed care plans accountable for cessation outcomes and by covering nicotine replacement therapy for quit line participants. The upcoming procurement of Medicaid managed care contracts is a great opportunity to prioritize cessation. This bar chart shows that we have lots of room for improvement in terms of Medicaid enrollees accessing cessation help, given that almost half of working age Medicaid enrollees smoke in Ohio. Finally, I want to emphasize the importance of tailoring cessation services to meet the needs of people who are struggling. This bar chart shows the relationship between adverse childhood experiences and smoking. Experiencing trauma puts people at higher risk for smoking and makes it harder to quit. Here's a quote from an Athens mom who's trying to quit but is struggling to cope with other stressors in her life. Many of the people who are still smoking are those who need the most intensive help. A doctor just giving them a pamphlet or a passive referral is probably not going to be enough for many. We also need to remember that there are higher rates of smoking among people with disabilities and people with mental illness, so cessation programs need to be tailored to meet their needs. The second part of this vision is about young people. As you may know, the Surgeon General released an advisory on e-cigarettes last year. The increase in e-cigarette use among high school students threatens to undo all of the progress that we've made reducing youth cigarette use in recent years. Here's what it would look like if we took youth prevention seriously in Ohio. Imagine that all tobacco products, including e-cigarettes, are more expensive and harder to get. For example, that cigarette and other tobacco product taxes go up, that the excise tax applies to e-cigarettes, more on that in a minute. Sales are limited to adult-only stores, and a strong Tobacco 21 policy is enforced. And we have youth-oriented media campaigns, and local communities are mobilized to keep kids tobacco-free. That's the vision. To recap, this is the vision for what it would look like if we were to address tobacco use in a serious way through policy change in Ohio. So now the question is, was this vision realized in the recently passed 2020-21 state budget? Well, there's progress to report in some areas, but certainly much more work to be done. First, I'll talk about the e-cigarette tax, which applies to nicotine vapor products. They are now subject to an excise tax. So this is new. Before this change, there was no excise tax on these products. Given that increasing the price of tobacco and nicotine products is one of the most effective ways to reduce use, this is an evidence-based policy change. So yay, Ohio. Now looking at Tobacco 21, as of October 17th, 2019, the minimum age to purchase tobacco products in Ohio will be 21. Given that most people who smoke started before age 21, this policy change has the potential to have a positive impact. But some advocates were concerned that the law did not go far enough in terms of enforcement. Some local communities, including Columbus and Cincinnati, have already passed stronger Tobacco 21 laws that involve tobacco retail licenses, allowing for stronger enforcement. And local communities that have not yet passed their own ordinances can still work to ensure that Tobacco 21 is well enforced, is carefully implemented, and done in an equitable way. Finally, looking at tobacco prevention and cessation funding. Unfortunately, this funding in the ODH budget did go down slightly. In the recent budget, Ohio was already spending only 11% of what CDC recommends for tobacco prevention and cessation, so this remains an area of concern. I'm going to close with 3 things that you can do to improve health value in Ohio. First, you can help us to spread the word by distributing the link or hard copies of the dashboard. You can order hard copies of the summary or the full version on our website. We also encourage you to use social media, particularly Twitter, to spread the word about the dashboard. Second, you can select one or more of the 9 strategies here and advocate for them. So if you are able to lobby, do that, or educate policymakers about these issues. You can certainly meet with, when you meet with legislators, we encourage you to share the executive summary of the dashboard with them, and we're happy to provide you with those. Finally, you can work toward equity. This slide highlights ways that you can focus on equity as you use the dashboard findings in your work. You can use the equity profiles in the dashboard to get started. And if your organization collects data, please be sure to collect and share disaggregated data. Here's a recap of what your organization could do. In that poll that Reem had earlier in the webinar, we saw that 48% of you had not yet used the dashboard. So we really encourage you to do one of these things or maybe use the dashboard in some other way. And now we're going to ask you another poll question to get a sense of how you plan to use the dashboard. How does your organization plan to use the 2019 Health Value Dashboard? And you can select all that apply. So are you planning to disseminate it to your partners, educating policymakers, advocating, or lobbying, using the findings to address health equity in your community or organization, or identifying organizational or community priorities. And we really want everyone to engage in the poll. So we're going to give it a minute here so we can hear from all of you. If you have additional ideas about how to use the dashboard that are not reflected here, please use the question box and let us know what those ideas are. There might be some great ideas out there. And if you've used it in the past and want to share an example of how you used it, you could also put that in the question box. All right, now we'll see the results. Okay, so the biggest one was to address health equity. That's fantastic. And lots of dissemination, little bit less for advocacy and lobbying, probably because some of your organizations may be limited in what you can do in terms of lobbying, but you can always educate policymakers. Great, thanks for sharing that. And now I'm gonna pass it back over to Reem to introduce our panelists.
Before we get to our panelists, we just wanted to share our three key takeaways from the dashboard, which is that Ohioans, as you saw, are less healthy and spend more on healthcare than people in most other states. As Amy shared, improvement is possible. There are evidence-based strategies that can be deployed to advance health value in Ohio, and we've highlighted 9 of those strategies in the dashboard. And of course, you can play a role. Amy shared a list of ways that you could engage in improving health value in the state and use the dashboard in the work that you do. All right, so now I'd like to introduce our first panelist, who is Bree Lushik. She is the Deputy Director of the Children's Initiatives in the Governor's Office, and we'll be talking about the strategies and policies that have been implemented in the budget that align with our first policy priority area, which is creating opportunities for all children to thrive. I'm gonna hand it over to Bree.
Thank you so much, Reem. Really looking forward to being here. So we will be talking a little bit about creating opportunities for children to thrive, as Reem said. But first, I really kind of want to give an overview of what exactly Children's Initiatives is and the goals that we have. One of the first things the governor did upon taking office was sign the executive order here that created Children's Initiatives and named Leanne Cornian as director, who reports directly to the governor. And her sole focus is coordinating children's programs across all state agencies so that they work better for children and families that they serve, so we can get to some of those goals of creating opportunities. In addition, Children's Initiatives is leading the charge on priorities such as lead poisoning, hunger, and child obesity, at the same time as identifying ways that programs and agencies can work together more efficiently for Ohio's children. As outlined earlier, here are some of the things that we're going to dive into, specifically around the investments in evidence-based home visiting that the governor set forth in his introduced version of the budget, and what we see in the final version of the budget, expanded access to quality early childhood education, what we're doing in that space, as well as expanding access to lead screening and abatement services. Increasing investments in home visiting. So one of the first things that we did early on was the governor's advisory committee on home visiting. And in that report, seen here, we outline a few many recommendations, but a few I wanted to mention are making race and ethnicity foundational elements, publishing regular, transparent reports on home visiting programs, and looking at incentive payments, Medicaid involvement in ways that we can further collaborate together, but a little bit more about our home visiting program. Help Me Grow is a jointly administered program between Ohio Department of Health and Department of Developmental Disabilities, providing home visiting and early intervention services to more than 30,000 families a year. And part of the governor's goal that he set out with creating that advisory committee is tripling the amount of families that are served through our home visiting program. The budget invests an additional $30 million over the biennium to expand evidence-based home visiting services through the Department of Health. That brings total state funding for evidence-based home visiting to nearly $70 million over the biennium. The budget also includes an additional $24.4 million in funding to expand eligibility for early intervention services. And as many of you know, as of July 1st, children with toxic lead exposure and children born with neonatal abstinence syndrome now have categorical eligibility for early intervention services. Expanding access to quality early childhood education. In this budget, we were able to invest more than $208 million to provide additional state and federal funding to improve the quality of childcare in Ohio. More than $99 million will be deployed to bring providers' base rate to the 25th percentile of market rate. And that is what we're seeing here in that the three clusters represent the different payment based off location and market rates in those areas, as well as the first is that base rate, and then moving up through the Step Up to Quality initiative, that 1, 2, 3, and 4, and 5-star rate that is increased based off those quality initiatives. We know that quality child care starts with quality educators, and our hope is that this funding will be used to recruit and retain qualified educators and offer equal access to quality child care settings for more of Ohio's children. In addition, one-time $10 million investment will help child care providers access the capital services and resources they need to become quality rated and better service children. It's also with this investment that the governor sees the need to improve quality before we can move the needle on the quantity and the amount of children served from the right now 130% to the goal of a future investment of 150%. And lastly, expanding access to lead screening and abatement. The governor feels strongly that it is wrong in 2019 that there are still children whose opportunities are stifled because they live in homes where they are exposed to lead paint. Here you see the heat index of the number of children with confirmed blood levels above that 10 microgram deciliter. The budget invests $25 million over the biennium to address lead poisoning. This includes annual investments of more than $4.8 million to advertise lead-free homes to families, abate and remediate lead contamination, and demolish lead-blighted homes, $225,000 to increase the supply of lead hazard control workers, and $5 million per year to provide lead abatement tax credit, allowing eligible individuals to receive income tax credit worth up to $10,000 for costs relevant to home lead abatement. And we're excited that Ohio just announced CMS approval of our lead state plan amendment, which allows great flexibility in our lead initiative. Specifically, it removes administrative and financial requirements that homeowners provide a financial match and proof of homeowners insurance, allows funding for workforce development, allows new types of properties to be eligible for abatement, including non-primary residence if a child or pregnant woman spends more than 6 hours per week there, this is great for grandparents, house, or licensed childcare providers. Additionally, it adds flexibility to use program funding for primary prevention activities. That could be HEPA vacuums, water filters, and other cleaning supplies. And we're really excited about the initiatives mentioned and ways that we can continue to improve for Ohio's children. And with that, here is Leanne's contact information, and I will turn the mic back over to Amy.
Thank you, Bree. I'm now going to transition us to the topic of housing and to introduce our next speaker, who is Kellen Craig with the Ohio Housing Finance Agency. Take it away, Craig.
Development and rehabilitation of affordable rental housing through the Housing Tax Credit Program. Give me 1 second. Okay, I'm going to start over because I don't think anybody could hear me. Can people hear me now? Okay, apologies about that. All right, so again, starting with a brief infomercial about the Ohio Housing Finance Agency. We're an independent state agency. We're a hybrid between a government agency and a nonprofit. We facilitate the development, rehabilitation, and financing of low to moderate income housing. Our agency's programs help first-time homebuyers, renters, senior citizens, and others find quality, affordable housing that meets their needs. We do this by funding competitive fixed-rate mortgage loans, by providing financing for the development and rehab of affordable rental housing through the Housing Tax Credit Program, the issuance of tax-exempt mortgage revenue bonds, and other affordable housing programs as well. I appreciate the opportunity to be with you this morning. Now I want to discuss our affordable housing crisis, which is certainly not unique to the state of Ohio. As many of you know, housing is the most expensive item in the family budget, and 1 in 3 households are cost-burdened, overcrowded, or living in substandard conditions. 400,000 households in the state of Ohio spend over half their income on rent. Ohioans need approximately $15.25 an hour to afford their rent for a basic 2-bedroom apartment. And 8 of the 10 most common jobs in the state of Ohio don't pay more than this housing wage. And some other statistics: total homelessness in Ohio has increased 20% over the last 5 years to about 70,000. And children's homelessness has also increased 25% to nearly 21,000 in the last few years as well. We know that homelessness and unstable and substandard housing conditions can lead to poor health outcomes, including asthma, lead poisoning, food insecurity, chronic disease, infant mortality, and other health issues. Many of you are aware of the research done by Dr. Megan Sandell, professor of pediatrics at the Boston University School of Medicine, who has talked a lot about housing as a vaccine. So it's in that vein that I want to talk a little more about Ohio's efforts to create affordable housing with accompanying services. I'm going to run through all these here quickly at once. This drives our efforts to make targeted investments in affordable housing. We aim to provide affordable housing opportunities for a range of incomes, family types, and vulnerable populations. This includes supportive housing for chronically homeless individuals and upstream populations like transition-age youth who are transitioning out of foster care, individuals with developmental disabilities who want to live in community-based settings, households recovering from opioid addiction, new or expectant mothers who are at risk of infant mortality, among many others. We try to incentivize development in areas that are well connected to services, amenities, transportation, and economic activity. This helps ensure residents are not socially or economically isolated, or that we're causing them further strain by being in a location that isn't connected to healthcare services and other amenities that they need, while trying to limit expenses for things like transportation at the same time. We incentivize the incorporation of comprehensive health and wellness supports into our developments. Health and wellness, of course, is becoming increasingly visible and critical issue in communities, especially among the lower and moderate income families that we serve. Therefore, we incentivize wraparound services, community connections, and on-site solutions for residents to improve and maintain their overall level of health and wellness, be it social, mental, or physical. This brings me to this year's biennium budget. This year's biennium budget, of course, contains several housing-related initiatives, including an increase to the annual appropriation for the Ohio Housing Trust Fund, an additional $2.5 million a year for the Ohio Department of Health to address youth homelessness issues, as noted earlier, new funding for recovery housing, and of course, new funding for lead abatement of homes and demolition of homes, some of which will be spent in partnership between OFA and the Ohio Department of Health. Most importantly, we know that Governor DeWine and his team, including Bree and Alicia, are looking at these issues closely and holistically, knowing that they're all interrelated. Because we're a beneficiary and user of the Ohio Housing Trust Fund, I'm going to focus my remarks on that. One of OFA's primary funding sources is the Ohio Housing Trust Fund, and we're of course thankful for our longstanding partnership with the Ohio Development Services Agency, who is the administrator of the program. The Ohio Housing Trust Fund is used to fight homelessness and tackle housing affordability challenges for veterans, children, and individuals with disabilities, while also enabling Ohio to tackle healthcare issues, infant mortality, child welfare issues, etc. So the Ohio Housing Trust Fund was established in 1991, and in this year's budget, there was an appropriation for an additional $2.5 to $3.5 million a year, based on a small fee increase. And that's the first increase that the Ohio Housing Trust Fund has received in 16 years, which is very exciting for those of us in the affordable housing world. And each Housing Trust Fund dollar leverages over $8 in private and federal matching funds and generates nearly $12 in economic activity. So not only is it a tool that can impact our health in Ohio, it also has the ability to generate economic development activity throughout the state. So big picture, new investment in housing equals a stronger, healthier Ohio. And with the increased fee in this budget, Ohio will see the benefit potentially of the full $50 to $53 million annual appropriation for the first time since the Great Recession, which is very exciting. I'm going to talk a little more about specifically what the Ohio Housing Trust Fund is used for. The trust fund is used for private homeowner rehabilitation, rental rehabilitation, home repairs, tenant-based rental assistance. It's also used to fund emergency shelter operations, homelessness prevention and rapid rehousing services, and it's also used for the new construction and rehabilitation of multifamily rental housing. And then last but not least, it's also used to provide funding for operating support and services for permanent supportive housing developments. At OFA, we primarily use the Housing Trust Fund to fund the new construction and rehab of multifamily rental housing. The units that we build with this resource serve individuals at or below 50% of the area median income. In 2018, I'll just mention that we used $13 million to fund 14 projects in 14 different counties. These developments included over 900 units of housing serving in excess of 2,400 individuals, many of whom are seniors, individuals with disabilities, persons with severe and persistent mental illness, or individuals recovering from alcohol or substance abuse, all who need stable housing and whose health outcomes will be better because they're stably housed. With this $13 million investment, we leverage an additional $128 million in public and private investment. Without this critical resource, many of these developments would be financially infeasible. And this gap financing enables these developments to take on less debt, decreasing their debt service, that cuts into operating and maintenance expenses and enables them to serve households at lower area median income levels, say 30% AMI and below, individuals who are most in need in our state. And I guess I'll finish by just saying, in closing, we're thankful that the General Assembly increased the amount of funding available in the trust fund and believe that continued investment in resources for affordable housing will help to begin to address many of the issues raised by HPIO's Health Value Dashboard, and this is a great first step in the right direction. Thanks.
Thank you so much, Kellen. That was a great overview of affordable housing and the work of the trust fund. And I'm going to transition us to our third speaker for today, who is Alicia Nelson, Director of Recovery Ohio. And hopefully we will be able to hear Alicia. Go ahead.
Good morning. Hello, everyone, and thank you for having me on the call. Last but not least, I'm happy to share a little bit of detail about what Recovery Ohio is, as well as, crossover between the two presentations that you've heard before and how they all relate together to serve people who are struggling with substance use or mental health disorders. So with that, I'll jump right into the next slide and talk about, really similar to children's initiatives, the governor on his first night in office signed a Recovery Ohio executive order, which gave us the ability to reach into all the agencies, boards, and commissions to really start to work to collaborate to solve problems as it relates to Ohio's prevention education efforts, making sure that treatment is available for those who need it and is available and accessible to those who need it, and provide support services for those in recovery and their families. And so we've been proud to work on what this looks like and really put some substance behind Recovery Ohio that I'm excited to share with you all today. The next slide shows a photo of the group, understanding that all good ideas don't lie within the state agencies and the boards and commissions that employ state employees, but actually there's a lot of great work already happening on the ground with all of you. We wanted to make sure that we had a standing representation of treatment providers, individuals in recovery and their families, law enforcement, healthcare practitioners, advocacy groups, commissioners, and the list continues to go on, of people who really understand these issues and can speak to what you guys are feeling and experiencing as you try to work and address these problems, and give us the feedback that we need to continue to make good policy decisions. Next slide, please. So to do that and really serve as a North Star, if you will, for how the state can address these issues, the governor, through executive order, created that group, and in that executive order tasked us to create a report that gave an overview of where we are in addressing the epidemic, that is equally focused on mental health disorders as well as addiction, and what we need to do at this point in time to move our state into a healthier position. And so what we did was put together the report that had 75 recommendations. Next slide. And then the report, it touches on a number of key areas. I won't go through all of these. I will make sure that you all know that on the governor's website, governor.ohio.gov, the report is available and can be accessed, that deals with these 9 topic areas and goes into great depth and detail about what the 75 recommendations are. Next slide. The important part is, how are we going to get those done? And with 75 recommendations, if you guys can imagine, a lot of folks were saying, well, where do we start? And it kind of feels overwhelming when you look at how multifaceted an issue like the epidemic that addresses mental health and addiction is. We, all felt overwhelmed at some point or another as we address this. Well, for Recovery Ohio, we wanted to make sure that we took a collaborative approach to addressing this, that not only incorporated the thoughts and opinions of all of you and the folks on the Recovery Ohio Council, which we consider our external partners, but also equally shared time with our internal partners and those state employees that have to make policy, funding, and other programming decisions to really respond to the 75 recommendations in the report. And so we really view ourselves as the bridge between, the external universe that continues to work on this and the internal work that our state agencies, teams, and groups like Children's Initiatives and the Ohio Financing Agency are working on to address these issues. Next slide. As it was touched on, one of the tools that we use to kind of further the work of the Recovery Ohio Council report that I just touched on was the state budget. And in the governor's executive budget, we introduced a number of landmark investments, historic investments in both the Children's Initiative space as well as the Recovery Ohio space, to the tune of $1 billion in new investments for these issues to make sure that we really address these health outcomes that we've talked about today and start to work towards a healthier Ohio. Some of these things were discussed already, so I won't go into much detail, but I will point out that prevention is a major theme of this work and of this budget, and we're excited to hear that we believe that, and others believe that this will be what we need to do to turn our state's health value around. Next slide. And when I read these health value findings, I was, not surprised, but also pleased to see that a lot of the work that we're doing correlates. And I think that, in the interest of time, I won't go too far into this, but we're really proud of the work that we did with Tobacco 21, prevention initiatives, really looking at K through 12 prevention education in every school, and also our collaborative work with the Office of Workforce Transformation that I believe will set Ohio down a path of success as we look at getting more people, into the behavioral health workforce and retaining those who have entered into that workforce by looking at payment rates, by looking at career pathways with higher education, and looking at what we can do even in the early years in our schools to make this an option for people to consider. Next slide. One of the ways that we plan to do all of this work, not only, using the budget as a tool, but we also will use the framework that was set forth by evidence through SAMHSA. And what you see here in front of you is an adjusted, kind of abbreviated version of SAMHSA's continuum of care. And really what we know is that all of us have a role as a part of the continuum of care. So next slide, please. What Recovery Ohio is trying to do is make sure that all of the agencies, boards, and commissions understand where they fit on this continuum of care. So if you guys could go to the next slide, you'll see that on that continuum of care, we have the Department of Mental Health and Addiction Services, the Department of Education, Department of Health, a number of groups that you may have suspected would be included, but we also talk about the role of the Department of Transportation and how transportation is an important impact. What can we do with veterans? How can we look at the aging population? All of these things are important keys to understanding that we're serving and all serving the same 11.7 million people. And the more that we understand that we're multi-system people and include each other in decision making and service delivery, the better patient outcomes and health outcomes we believe we will see. And so with that, I know we are over time, so I will stop talking. I'm happy to answer further questions. My contact information is on the last slide, and I'm just excited to be here.
Thank you so much, Alicia. I know that we have reached the end of our time as we've been receiving questions as they come in to the question box. We've been answering them there. We are happy to respond to a few additional questions via the question box for those who would like to stay on the webinar for a few minutes. Bree did need to leave. We do still have Kellen here with us. And Alicia, are you able to stay on the line for a minute? She might be unmuted now. Okay. And I also want to mention that a recording of this webinar along with the slides will be posted. And are we not able to advance to the next slide? Okay. Our slides are frozen. I'm imagining a fabulous multi-sectoral diagram from Alicia, which you'll be able to see posted on our website. And we are monitoring the question box here. I'm not seeing any additional questions come in. Oh, we do have a question. And it looks like this one may be for Kellen. Can you direct me to more information about safe housing as it relates to homeowners?
Well, I would, I guess, direct you to our website. Can you hear me?
Yeah.
Okay. I'm going to say www.ohiohome.org. We have, if there's someone looking for housing, we have Ohio Housing Locator on our website. You can also go to ohiohousinglocator.org if you're seeking housing, but we have a lot of information about our homeownership programs on our website. And if you're a homeowner seeking our programs, you can go to myohiohome.org to get directly connected to our first-time homebuyer programs, down payment assistance programs, etc.
Thank you, Kellen. I am not seeing any more questions come in, so we want to thank everyone for being on the webinar today. We know from the numbers that Reem shared earlier in the webinar that we have a lot of challenges facing our state, but we also, I think, have seen on the webinar today that improvement is possible. There are lots of partners around the state that are working on evidence-informed approaches to improve our outcomes and control our healthcare spending. And we look forward to working with all of you to spread the word about this work. Have a wonderful rest of your day. Thank you.